This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome everybody to another episode of PHM from Pittsburgh. I am your host, Dr. Tony Tarchichi. I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We are coming to you with the third in our crash course in adult inpatient care series. Again, this is geared towards those of us who are pediatricians and who are now, I shouldn't say us, I am not in that group yet, who are now being asked to see adult patients because of the COVID crisis, pandemic. We are trying to get out as much information as we can. I wanted you all to know this episode, we are cooperating with the Popcorn Network, which has sprung up and is a group of med peds and adult doctors and pediatricians and med students. I think there's over 200 to 300 people involved now who are trying to help create as much information for pediatricians who are now taking care of adults as possible. We have collaborated with them on this particular project, so thank you, Popcorn Network. As always, there is CME credit with every podcast. Thank you to the University of Pittsburgh, who takes care of that. This episode is directly because of a previous episode. We had done one on the pulmonary, the last one we had the audio troubles. Sorry about that again. We are now using Microsoft Zoom, so we should not have any audio troubles. It does a better recording function. And they recommended, intensivists in that episode recommended we discuss congestive heart failure because it's such a common occurrence in adults. For those of you taking care of adults, you may see a patient with adult CHF, which is different than pediatric CHF. So along those lines, the Popcorn Network has gotten in touch with our expert guest today, so I'm going to introduce him now. We are privileged to have Dr. Nathan McConkey on our show today. Dr. McConkey completed his DO and MPH at Des Moines University in Iowa and is currently a fellow training in cardiology at the Penn State Health Medical Center in Hershey, Pennsylvania. So he's a Pennsylvania person just like us. He has a particular interest in the care of adults with congenital heart disease, especially with regards to arrhythmia management, and is pursuing a career in electrophysiology to provide medical and procedural services to this unique patient population. So Dr. McConkey, thank you for joining us.
Thank you for having me.
All right. So Nate, this is going to be, we have to do our conflict of interest statements, our disclosure statements before we get any further. I will go first and I'll kick it out to you. I have nothing to disclose.
I also have nothing to disclose.
All right. So this is going to be interesting. We have to try to get through CHF, and I'm going to be very honest to those of you listening. I haven't done inpatient adult medicine in over 2 years now, so it has been a while. It's amazing how quickly you forget things you don't do regularly. So Nate, I'll ask you the first simple, straightforward question. Can you explain to us congestive heart failure for adults in general, and you're welcome to go through systolic and diastolic if you wish, to a pediatrician who has not seen it since medical school, let's say?
Sure thing. So the unifying features for heart failure, whether it's congestive or high output, systolic or diastolic, all involves insufficient cardiac output to meet the metabolic demands of the body. So what that can take the form of is either decreased outflow because of a weak heart squeeze, or difficulty filling in between beats in the case of diastolic dysfunction, or a setting of increased metabolic need where the heart, for whatever pre-existing reason it may have, is unable to keep up with it. In adults, in contrast to pediatrics, the most common reason we see that is typically congestive heart failure due to decreased pumping function. That can be systolic or that can be diastolic as well. I use those terms similarly when I talk about the pumping function overall. In contrast, in pediatrics, we're accustomed to seeing things like shunting, pulmonary overcirculation, more so than actual pump failure per se. So this remains one of the leading causes of death in the US. It's one of the top 3 reasons for admission to an inpatient adult ward. It's something that we see very commonly for a number of reasons. The biggest things that we see are usually in association with ischemic heart disease from coronary disease or longstanding hypertension. So in recognizing heart failure in adults, the cardinal symptoms we usually expect are shortness of breath, exercise intolerance, and evidence of end organ compromise. It's not common to see things like chest pain or tightness, although depending on the comorbidities, that may be part of the presentation as well. But one of the most common dilemmas we see in the emergency department is the patient with undifferentiated dyspnea. And the question is this COPD, is this pneumonia, or is this heart failure? So as we go through, we can talk a little bit about some of the distinguishing features and how the presentation can guide the management for each patient.
Well, so the next question I had was, can you explain what is an exacerbation, what triggers it? So how does a patient who has CHF and presents with an exacerbation, how do they look?
Sure. So because heart failure is typically a chronic condition in adults, you have kind of a rising and falling, waxing and waning pattern to it. And the classic story is someone who was previously hemodynamically well and euvolemic. They may have an episode where they overindulged on a holiday dinner or skipped taking their diuretic medicines, had a high salt or high fluid intake as well. And certainly if they have any underlying infection, that can trigger this too. So the patient usually comes in complaining of, again, shortness of breath is the most common presentation for it. Some features on exam that we usually find include things like diffuse edema, JVD, crackles in the lungs. Often at that point, they've also had some X-ray findings. You may see signs of pulmonary edema and certain laboratory findings as well. Most commonly, we see things like an AKI, a rising BNP, B-natriuretic peptide level, and sometimes more severe signs of end organ involvement, like liver dysfunction from congestion or even a rising lactate in some cases.
If I'm a pediatrician and I see a patient who has those symptoms and I get a BNP, is there a number I'm thinking about or looking for to say, this is probably CHF exacerbation, maybe not a COVID-19 or a regular pneumonia causing CHF exacerbation?
It's usually more convincing when you have numbers in the high hundreds to thousands range. And bear in mind, there's BNP and also pro-NT BNP. So it may depend on what specific assay your institution uses. But usually a good rule of thumb is 3 or 4 times the upper limit of normal. However, it's worth noting that patients with chronic heart failure often have some BNP even at baseline. So in that case, when a patient with a high BNP comes in, I'll usually pull up their last year of labs and see, okay, what do they usually run when they're said to be euvolemic? There are a few things that can fool a BNP as well. Patients who are obese tend to have lower levels. Patients with external constriction on the heart may also have lower levels. But typically for patients who've had these sorts of conditions, it's a frequent occurrence for them. There's often some baseline data to compare it to see if it's really elevated for that patient.
How important or how predictive of a sign is orthopnea in your history for congestive heart failure versus a pneumonia?
So orthopnea is fairly typical for left heart failure. And again, one thing that differentiates our patients from pediatric patients is left heart failure far outweighs right heart failure. So patients who come in saying, when I lie flat, I can't breathe, I prop myself up in pillows, or more commonly, I sleep in the lazy boy recliner, which I've done for the last 20 years. That's a common story. I wouldn't rely on it 100% because there are situations where orthopnea is less sensitive. In order to have orthopnea, you have to have left heart failure out of proportion to right heart failure. So the idea is the right heart can pump blood into the pulmonary circulation, but then the left heart can't get it back out. But patients with biventricular heart failure often lose their orthopnea. So it's actually an ominous finding when a patient who used to have orthopnea all the time suddenly loses it and you didn't do anything to fix it. So the absence of orthopnea doesn't rule out heart failure, but the presence is fairly specific.
So now if I've recognized this patient has a history of CHF, they're coming in with JVD, the chest x-ray says pulmonary edema, what steps should I take in terms of treatment? What should I be thinking about to treat this patient?
So 95% of the time, a heart failure patient who comes in needs diuresis as their first step. They all need diuresis eventually, but some may be a little more complicated than that. Usually what ends up happening with these people is if they miss a dose of diuretic or they have a dietary indiscretion, that same edema that you see in their lower leg and their abdomen is in their gut as well. And that decreases their ability to absorb medicines, including diuretics. So very frequently, all you may need to do is give the same dose of diuretic IV to bypass that effect, and then you can get things moving again. So the most common diuretic we have people on is Lasix, which pediatricians are well familiar with. We also have some things like Bumex and torsemide that may not be as familiar, but generally speaking, if you take the dose that they're on at home, if it's an oral dose, give the same number of milligrams IV. 40 milligrams Lasix PO, give them 40 IV. That amounts to a twofold increase in the actual potency of the dose because of the bioavailability of Lasix. And so often that's enough to get them to start putting an output. Usually our goal with these people is to get at least 1 liter out in the first 24 hours. Certainly you can go faster than that if they're in dire straits, but the biggest reason for the failure to treat heart failure is insufficient diuresis when they hit the door. So that's usually the way that we go for patients who can tolerate diuresis. The one situation where things get a little sketchy is when there's concern that they're also hypotensive. Many of those patients will still tolerate gentle diuresis. The idea being if you can decongest the heart and decrease the size of the ventricle, it actually pumps more effectively. So although they have less fluid in their system, their blood pressure will paradoxically go up. It's just important to recognize when a patient is becoming too hypotensive that they're on the border of cardiogenic shock, and that's a whole discussion in and of itself. But usually you're not wrong by giving them a dose of diuretic.
So if I'm seeing them on the inpatient side, not the ER, and they take 40 milligrams of Lasix orally, you're saying I can just try 40 milligrams IV daily to see where that gets me?
You can do that. Typically, we prefer to give it at least BID, only because for patients on chronic diuretics, they'll often compensate if you give them a single dose of Lasix. As the name suggests, it lasts 6 hours, which means they've got 18 hours to try and undo the efforts of it. So normally what I'll do is I'll give the home dose IV to see what their response is, to make sure they can have a urine output. And once I've found a dose that works, I'll usually increase that to BID, aiming for that goal of 1 liter per day out, net negative, that is.
How quickly do they feel better? How quickly do they tell you they feel better after this all starts out?
Usually they should feel better by within 6 hours or so of getting their first dose of diuretic. And one thing about Lasix that we often forget is it actually does work as a mild venodilator. So in addition to decreasing the total volume that contributes to preload, it also reduces the amount of venous return, which has some effect even before they put out a drop of urine. So from that alone, patients often feel better after their first injection. Others, especially if they've been behind the 8 ball for a long time, may take a day or two of decongesting and losing liters and liters of fluid before they start saying, yeah, I can finally lay flat and breathe normally now.
Now, the ones who come in for CHF exacerbation are probably on antihypertensives like ACE inhibitors, ARBs, maybe calcium channel blockers.
Yes.
I'm assuming we should continue those unless there's a hypotension issue or another contraindication.
That's correct. Paradoxically, patients with systolic heart failure actually derive a long-term positive inotropic effect from medicines like beta blockers. In the short term, giving them a beta blocker will decrease their squeeze, and of course their heart rate goes down with that as well. But it's actually more dangerous to abruptly withdraw a beta blocker, in particular in these patients. ACE inhibitors and ARBs are a little bit more forgiving if you have to stop them, especially if the patient comes in with a significant AKI. But unless they are hypotensive as well, we do prefer to keep those medicines on. As far as calcium channel blockers go, it would be uncommon for a patient with heart failure, severe heart failure, to be on a non-dihydropyridine calcium channel blocker like topiazine, although certainly it can happen for other indications like AFib. Those we will occasionally hold, but your plain old dihydropyridine, amlodipine, ifedipine, et cetera, we usually keep those going.
If I have to stop one because of low blood pressure issues, I'm going to try to keep beta blockers going. And if I have to stop, I'll stop others.
Yes. Now, if it comes to the point that you need to start the patient on pressors, obviously we stop the beta blocker. You don't want to step on the gas and the brake at the same time, so to speak. Right. But yeah, we would prefer to keep the other ones off because withdrawing from beta blockers can worsen heart failure.
How do I know if I'm getting to the point where I really need to think about pressors? At that point, if they're on pressors, my assumption is they're going to be on a cardiac team or some sort of cardiac ICU, or at least a step-down unit, and probably out of my care as a pediatrician.
Right.
But how do I know I'm getting to the point, I'm managing this patient because we're so overwhelmed with COVID patients, they asked me to take this one on. How do I know when I should consider, I have really need to think about pressors here? Okay.
So there's 2 questions in that. So there's the need to start pressors, and then conversely, and somewhat unique to adult heart failure, is the need to start inotropes. So we'll start patients on pressors when we find that their blood pressure is too low to tolerate continued diuresis. Now, patients with chronic, especially systolic heart failure, often tolerate very, very low blood pressures. It's common in our ward to have patients, sitting up, chatting, being perfectly fine with systolics in the 80s. Now, it's one of those things where we try to treat the patient more than the numbers. If they're not symptomatic with hypotension, we tend to forgive just about any number. bearing in mind that's assuming their baseline is low and they've been habited to that for a long time. But when it starts getting to the point they're complaining of lightheadedness, they're saying, hey, I think I was feeling better and now something else is going wrong. And when you're seeing signs of end organ compromise despite diuresis, that's when we start talking about pressors. And typically, the pressor of choice we would use is actually Levophed if you have to start something in a hurry. It can be tempting for people treating systolic heart failure for the first time to consider an inotrope like dobutamine or milrinone, but it's important to keep in mind those will decrease blood pressure before they increase it. So patients who are on that edge where they might be going into shock, we don't always start inotropes right away because that can actually make things worse. So the secondary question to this is, when do I start an inotrope? Which is a separate question and a more challenging one to answer, is when we're seeing signs of cardiogenic shock. And when most people, and especially in the pediatrics mindset, when we think of shock, we think of sepsis, a patient who's lying in bed, ill-appearing, rigoring with a toxic appearance. Cardiogenic shock is a lot sneakier than that, and it's something that routinely fools providers because of how healthy the patient looks. Patients can walk in on their own 2 feet and say, I'm here for my annual cath because I'm getting a workup for a heart transplant, and then we get the numbers shriek in horror and they spend the next 3 weeks in the ICU. So what we're looking at is patients with signs of end organ compromise out of proportion to hypotension and clinical illness. And it's important to recognize this. Heart failure, when it gets ugly, it doesn't always happen because the blood pressure is getting low. When people are in cardiogenic shock, they usually have peripheral vasoconstriction, and their blood pressure can actually look normal even though they're hypoperfusing their organs. And to kind of use a thought experiment, if I pick up a bag of saline and squeeze it really hard, I can make it get to 100 millimeters of mercury. Nothing is actually flowing. And likewise, in a patient with significant heart failure, they can have a normal blood pressure from the vasoconstriction alone, but the organs aren't actually seeing that pressure and the blood isn't actually flowing significantly. So when that happens, we see a very unique situation where you can have a blood pressure of, I think the last one I was consulted on had a blood pressure of 100/75, which is unusual, but not where we think of a patient being in shock. And his index was 1.5, and less than 1.8 is considered cardiogenic shock. So these patients will have a lactate that's going up, liver enzymes that are getting worse, often a creatinine that goes up, and it doesn't make sense based on the hemodynamics. Their heart rate may be normal to mildly elevated, but the blood pressure is often normal.
Can you explain the index to us, please?
Oh, sure thing. So when we talk about pump failure as opposed to shunting heart failure, we're talking about the output of the heart in liters per minute, and usually we index that based on body surface area. So a normal cardiac output may be about 5 liters per minute or so. And a normal cardiac index is usually over 2.5 to 3 is the range where you're not in cardiogenic shock territory. Once it gets less than 1.8 or less than 2.2 on inotropes, so when we start to call it shock. This is one thing that can be especially tricky when thinking about the hemodynamics in heart failure, however. It's not just the blood pressure that you're going by or the heart rate. It's also the venous pressure, which we don't always directly measure. The reason why their renal function may be declining or their liver enzymes are getting worse, it may not be that blood isn't getting to the organ, it's that the venous end is not being decongested. So if you have, let's say, a MAP of 65, but a central venous pressure of 20, then the actual perfusion gradient that's sending blood through your organs is about 45. So recognize how that patient would be worse than someone who had a MAP of 75, but a CVP of 5. So that being said, it can be a little bit sneaky. Cardiogenic shock can creep up on you. So when you get those patients where the numbers are getting worse, even though their output seems to be good, and it's not explained by hypotension, those are the patients that we'll often send to the ICU and start on milrinone. Or if we're unsure, we'll even do a right heart cath to get their numbers specifically. And I can't emphasize enough, this is the sneakiest thing that heart failure can do that people need to be aware of.
So if I'm taking care of a patient and they come to us for whatever reason, and they're an adult with heart failure, I'm just trying to think this through, and I see a blood pressure that seems fine. Because again, a pediatrician, we may not balk at a blood pressure systolic of 80 because we're used to it in kids, but let's say it's 100/75. Is the cardiac index that we were talking about, the one above 2.5 is ideal? I've never seen that in terms of a flow sheet or on vitals. Is that something I have to calculate, or is that usually given when the patient admitted? The EMRs usually do it for you.
The most likely place you are to see an estimation of it is on an echocardiogram. It's not something that can be measured just on the exam. You have to have something something to point out to you. And I bring up the idea of an index just to describe the relationship between pump failure, the size of a patient, and the organ involvement, but you may not have that number readily available.
The way I'll recognize this or pick it up slightly is I have the patient in front of me with seemingly fine vitals, seemingly, and then their creatinine is high, their LFTs are high. I'm seeing more organ damage than I expect to, but you're saying they could be sitting up and talking to you.
That's correct. They may not show any signs of illness on exam.
So they may not be short of breath. They may not have any of those, but then when you do labs, you'll find this. Is that fair?
That's fair. And the other thing that people will find is evidence of fluid overload. So like I talked about earlier, the shortness of breath, the orthopnea, the PND, the paroxysmal nocturnal dyspnea, waking up like you can't breathe, those may go away as heart failure progresses to the point that your left and right heart failure are both equal. But you will still have signs of fluid overload. The one that most people tend to miss is the JVD, especially because we're not accustomed to looking for that in pediatrics. Generally, what we have patients do is turn their head to the left and look to the ceiling. We don't try and have too much tension to the neck, or that can push down against it. And then looking sort of across tangentially at it, we'll often see two distinct peaks, one from the carotid impulse and one from the jugular venous pulse. That's something that people have to be accustomed to looking for, because that can often be one of the first, if not the only, signs. Often adults on medicines like amlodipine may have lower limb edema, and that's a good explanation for it that may lead you to think, oh, maybe it's not heart failure. But there are no benign causes of JVD in most adults. So learning to recognize that's going to be the most important part for telling that it's a cardiac etiology.
So now we've talked about what it is and how to recognize it if you're seeing an adult on the inpatient side, and then even treatment for it. Can we talk about it in terms of this COVID-19 pandemic? We
Yes.
know for COVID that x-rays are showing typically multifocal pneumonia. Patients are coming in with shortness of breath and hypoxia when they're coming into the hospital. Some are fine at home. Do you know, are you seeing patients come in with COVID-19, shortness of breath, and CHF exacerbation? Is one causing the other to flare up?
Yes, we are. And in addition to that, it's also less common but reported that COVID itself can be associated with myocarditis, and that too can cause heart failure. Now, even before the age of COVID, this was a dilemma we were accustomed to seeing, because it's not uncommon that someone has the audacity to come in with both pneumonia and heart failure at once. And unfortunately, the fluid management tends to be the opposite for both of them. But often, in the absence of a silver bullet to say, oh, this is clearly the cardiac element and this is clearly the infectious element, what we'll usually see is someone coming in looking clinically dry in the setting of sepsis. We rehydrate them, and their creatinine goes down and then starts going back up again. You hit an inflection point. Typically, when we don't have a clear-cut answer on what's going on, we will still resort to trial and error. We'll say, okay, let's pick a lane. Do we want to diurese them or do we want to rehydrate them, and let's see what happens. And so for these patients, it's unfortunate that with this particular illness, we're trying to run them on the drier side. We will often try and fluid restrict them, since there may be some evidence that decreases the onset of respiratory failure in these patients. But obviously, if they come in feeling ill with poor PO intake, they may need some fluid resuscitation, and that's perfectly appropriate. I haven't seen anyone who's come in with COVID and such fluid heart failure that giving them a bolus when they're hypotensive would have done them harm. That can happen for just pure heart failure exacerbations, but fortunately, that is not what we've been seeing so far with COVID. So I guess to summarize then, if you're not sure which it is, often if they're hypotensive or if they look dry on exam, giving them a small bolus like 250 to 500 cc's at a time is appropriate. And then we recheck our labs and exam to see if things have gotten better or worse. And if they got worse, you turn around and go the other direction. Now that assumes that you've been carefully quantifying everything, making sure the eyes and nose are accurate, making sure that if you are trying to diurese them instead of rehydrate them, they actually are net negative, since oftentimes a failure of diuresis is often that the patient didn't diurese at all. But if you're certain that the numbers are correct and that you're moving the direction you expected with fluid, it's perfectly fine to change directions if you think you might have gone the wrong way.
When, as a pediatrician, I'm seeing a patient, they're in respiratory distress, they've been diagnosed with COVID, and they have CHF, at what point should I say to myself, I should really consult cardiology here?
You know, it's not a bad idea to do that in the get-go if you have a patient with a complex cardiac history. And especially our CHF patients with systolic heart failure, they can compensate relatively well and then crash fairly quickly. And obviously that's a phenomenon we're accustomed to seeing in pediatrics. But if you have a patient with a reduced ejection fraction, with advanced stages of heart failure or on multiple medications that may be conflicting with your management of COVID, it's not wrong to give us a call and we can make some suggestions. It doesn't necessarily mean that the heart failure itself needs to be managed in a different way, so much as it is just adjusting the care of the COVID in the setting of some of these complex comorbidities. So I guess that's a long way of saying, call us if you're uncomfortable. That's never the wrong thing to do. But especially a patient with an established cardiac history, or if they don't have an established history and they have new onset myocarditis, that also would be concerning. A shorter list of things might be reasons why we don't need to get involved necessarily. The only reason why we wouldn't necessarily make a change in management is, for example, isolated troponins without any symptoms or isolated EKG findings. It's not uncommon for a patient's first presentation of heart failure to be following a missed acute coronary event. We are actually seeing some patients who are delaying coming to the hospital because they're concerned about COVID exposure. And in the last month, I've seen 3 missed STEMIs. Patients were at home with these, said, oh, I just feel a little indigestion. I'm sure it's nothing. But if patients outside of a story like that come in, we happen to get a troponin and it's low positive, 0.04. They're not having chest pain. They don't have EKG findings. That's pretty much par for the course for COVID. Most of these patients will have a slight troponin. Conversely, many patients with pre-existing heart disease will have some nonspecific findings like T-wave inversions, or even some ST changes, maybe ST depressions in isolation. If there's no significant findings on exam, if there's no symptoms of angina, chest tightness, not shortness of breath, those don't usually change the management of those patients. The ones where we worry about things like COVID myocarditis are the ones with new onset heart failure without a prior history. They tend to have sky-high troponins and BNPs, and the EKG may show diffuse ST elevations or low voltage because the edema in the heart dampens the signs on the EKG. Those are the ones that concern us.
So for that, I'm looking for a patient who typically doesn't have a CHF history coming in with JVD with signs of CHF on exam, and then I'm getting troponins, they're sky high. I'm doing an EKG, maybe I'm seeing diffuse ST elevation. At that point, I'm calling you, we're getting an echo, and probably the patient's being moved to an ICU.
Yes, that's correct.
Otherwise, if I'm seeing a patient who's coming in with known CHF and has COVID, has some shortness of breath, I'm picking a lane. If they're hypotensive and I think it's from sepsis, from the virus, I'm going to rehydrate and see what happens to their labs, their physical exam, and their vitals. If I rehydrate them and I'm gentle, so 250 to 500 mLs of normal saline, if they go the wrong direction, get more shortness of breath, more issues, then I'm going to try to reverse course and diurese them. And if I'm getting uncomfortable, I'm calling you.
Absolutely, yes.
Okay. And everything else I said sounded reasonable. All right. Okay, great. That's all I had. Is there anything that we should discuss that I didn't bring up, Nate?
Well, one of the things that most commonly plagues adult patients when they come in with heart failure is arrhythmia. And if pediatricians taking care of adult patients have not been acquainted with it before, this may be the first time that you face atrial fibrillation. It is the most common rhythm that we find in heart failure patients. It is both a consequence of heart failure and a contributing factor to heart failure that needs to be addressed. And this is also one of the most common reasons why we're consulted. It's not wrong to call us for this, but recognizing the role that AFib plays in heart failure patients is important. So I do want to touch on that a little bit.
Sure.
1 in 4 adults will have AFib at some point in their life, and you're more likely to get it in the setting of an acute illness. And one of the most common things that we see as a heart failure exacerbation is the triggering factor. It's thought that one thing that leads to AFib is dilation of the atria. And when patients come in with fluid overload, they tend to have increased pressure in the left side structures of the heart. Very frequently, they'll generate enough left atrial stretch to go into fib. So it's fairly typical to recognize it on EKG. Everyone who's done an ACLS class will recognize the irregular rhythm without organized P waves. And often the patient will have heart rates in excess of 120, 130 or higher. Now, while some tachycardia can be common in heart failure, especially advanced stages of heart failure, the tachycardia you get with atrial fibrillation is often inappropriate. Normally, for a patient who comes in with AFib, our strategy is to try and decrease the heart rate with medicines like metoprolol, with diltiazem, and that's part of ACLS as well. However, in the setting of heart failure, giving negative inotropes and chronotropes will make the patient worse. There's very little you can do that hurts a heart failure patient more than starting a beta blocker or a calcium channel blocker during an exacerbation. The solution for this is usually to decongest the heart and decrease the stretch on the left atrium. So we often joke that Lasix is the best antiarrhythmic. For many of these patients, they'll return to a lower rate or even convert spontaneously just from diuresis alone. And so it's okay in some cases to think of the AFib like just pretend it's sinus tach. Pretend it's a sign that the heart is struggling and trying to beat more because it can't beat as hard. And then with that mindset, the usual therapies you'll have will also treat the rhythm. But when you reach the point where a patient is now euvolemic and their heart rate is still over 110, that's our usual cutoff, in those situations, we will try and slow the heart down. And there's a few ways we can do that. If we've officially said we're no longer in heart failure exacerbation, they're euvolemic, their pulmonary edema has improved, their organs are improving on labs, then it's appropriate to give some metoprolol either IV or if they haven't had it, PO to start at PO. For many of these patients, however, especially if they also have softer blood pressures, this is one of the few situations we continue to use digoxin in adults. And I probably used more digoxin in pediatrics than internal medicine, especially because of our neonatal arrhythmias with PJRT and the like. But in adult medicine, it's less commonly used, and you may even get an eyebrow raised or two if you try and order it. But in this clinical context, it makes perfect sense. We'll usually give either 250 or 500 micrograms IV, which will slow down the heart rate without significantly dropping their blood pressure. So that's the most common trick I use in these patients where you're between a rock and a hard place. There are some patients who have other reasons for having AFib, especially if they have mitral valve disease. Very commonly, patients with LV dysfunction with a big dilated LV no longer have a mitral annulus that completely fits together right. Those patients with severe valve disease will often have very massively dilated atria, and putting them back into euvolemia may not be enough to treat them. When you're in AFib, your cardiac output can drop by as much as 30%. So certainly it's not a good thing for patients who are in heart failure. If we find that we've done our best to control the AFib, it just hasn't worked. They seem to be well in every other account except their heart rate is still high and they're still having some palpitations or maybe a little dyspnea from that alone. That's the situation where we talk about cardioverting these patients. If you strictly follow ACLS or PALS guidelines, you might be tempted to cardiovert a patient way earlier than they would need to be. But for heart failure patients, if they're not euvolemic and you cardiovert them, they will immediately go right back into AFib. So it's usually our last resort in these folks. Another thing that pediatricians probably don't take care of very frequently is cardioembolic strokes from these patients. Having AFib significantly increases your risk of stroke because your atrium isn't squeezing. The blood can pool and coagulate. And once you start it squeezing again, it'll shake the dust off and those clots can go north to the brain. So a patient who has AFib must be anticoagulated if you plan on doing a cardioversion. If you didn't see them go into AFib and they walked in the door with AFib, we don't know how long it's been going on, but just 48 hours or even less is enough to form a clot, and that would be a contraindication to cardioverting them. So if you think that a patient's AFib or some other arrhythmia is the problem, consult cardiology. We may need to do a transesophageal echo first to look for clots before we convert them. It's not something that should be done at the bedside unless it's a dire emergency. When that's been done, however, or if a patient is fortunate to be on anticoagulation already, if they're known to be an AFib and they've taken their medicine on a daily basis, then it's not as much of a production to come in and convert them, sometimes even at the bedside in ICUs. So bear in mind that that is a tool available to you in treating heart failure, which often comes with arrhythmias, but it's not indicated as often as you might think, and usually treating the underlying cause will make it go away. So those are the big pearls for AFib.
What if I have a patient who comes in with AFib and congestive heart failure, and then I diurese them and they convert on their own back to a normal sinus rhythm?
Good question. Those patients also will need to be anticoagulated. Many people may remember from medical school the CHADS-VAS score, congestive heart failure, hypertension, age, diabetes, prior stroke, vascular disease, female gender. 2 of those is enough to merit anticoagulation. But even a patient without any of those risk factors, if they convert from AFib to normal rhythm, they are at increased risk of stroke for at least the first month afterwards. The electrical function goes back to normal long before the squeezing function. And if you look on echo at a heart that just came out of AFib, it squeezes about as well as a heart that's still in AFib. So those patients need to be anticoagulated, at least for the short term. That would also be a good reason to get us involved, since there are a lot more anticoagulant options out there than there were even just 5-10 years ago. But that's a very common question for us, and the answer is usually they need to be on blood thinner.
As a primarily pediatric hospitalist, I have not kept up with the changes in anticoagulants that have been available. So I would probably consult for that as well, because I know warfarin from my training.
But it still works, but yeah.
there's like 4 or 5 more since then, so that people are using. So I would definitely consult for that. So if I'm understanding this right, if a patient's in AFib, I can initially, I don't want to slow the rate down if they're in congestive heart failure with AFib, an exacerbation. I want to diurese them to get rid of some of that volume to see if that works. If they're euvolemic and they're still in AFib and their heart rate's still above 110, then I would probably call you all, but then we could start a rate limiting agent, and the digoxin, something you brought up, because it will slow down the rate without affecting the cardiac function.
That's correct.
But we would do that. I would do that with a cardiology consultant, not alone.
Yeah. I mean, it's because AFib is so common. Many of our adult providers will not give a second thought before managing AFib 100% on their own. But it's only because we see so much of it. And for someone who isn't as accustomed to treating AFib, it has a lot of insidious surprises in store for you. And we wouldn't take offense to any help, even for something that's otherwise common in adult patients. Another thing that's worth touching on is, again, just running on the theme of you're doing the right thing, but the patient isn't getting better. What else can I be considering? Certainly arrhythmia is one of the biggest things as well. But while we typically think of most adult patients with heart failure having either coronary disease or hypertension, those being the biggest two, there are some more sneaky causes of heart failure that you need to keep an eye out for. And none strike terror into the hearts of intensivists as much as a cardiac tamponade. So a patient who has myocarditis in the setting of COVID may also have some degree of underlying pericarditis and pericardial effusion. And so often we'll have a patient come in who looks a little bit ill, maybe they're hypotensive as well, and the question comes up, could this patient have tamponade? Because every tissue is stiffer in adults, an adult pericardium will expand only so much before it puts its foot down and doesn't expand further. That's a common theme in adults compared to pediatrics as well. And so in these situations, they can go from being relatively well-appearing to decompensating abruptly over the course of 10 to 15 minutes. So the big question on everyone's mind is, how can I detect pericardial tamponade? When should I suspect it in the differential of heart failure, and what do I do if I find it? I will note it is an uncommon reason for a patient to be in heart failure, but the symptoms can look similar. They will still have JVD, they will still have edema, they may have a vague sense of chest discomfort, and they may have shortness of breath. They may also be hypotensive to the point that we're in that territory where I don't know if I want to diurese them, should I give more fluid or should I take fluid away? The sine qua non of cardiac tamponade is usually pulsus paradoxus, and this is something that every provider is capable of checking for, although it's not something we're accustomed to doing very frequently. Pulsus paradoxus refers to respiratory variation in blood pressure. So everyone's blood pressure fluctuates a little bit when you breathe in and breathe out. When I breathe in, my intrathoracic pressure goes down, the venous return to the heart increases. When people have tamponade and there's only so much room in the pericardium, increasing the flow to the right heart causes it to intrude into the left heart a little bit. So then the left heart doesn't fill as much, and on that beat, the blood pressure will be lower. So typically what we find is someone whose blood pressure when they're breathing in is maybe more than 10 points lower than when they're breathing out. To clarify, that's tidal respiration. You don't tell the patient, take a breath in. You don't tell them you're doing anything. You just measure their blood pressure, and when they naturally breathe in and out, see how much it fluctuates. You can do that without a stethoscope by palpation. What I usually do is I put my finger on the radial pulse, I inflate the cuff until the pulse completely disappears. I'll hold it on that pressure for a few breaths and see if it comes back. If the pulse comes back and disappears without me changing the pressure in the cuff, that means that there's pulsus variation. It may not be more than 10 points. For that, I have to keep inflating it and keep decreasing it to see when it's either always present or always gone. But that range where it fluctuates, where it comes and goes with breathing, is the width of their pulsus paradoxus pressure. The reason why that's so important is because it is still the gold standard for diagnosing tamponade. Many people think, oh, if I get an echocardiogram, it will show, but tamponade remains a clinical diagnosis. On the echo, I can tell you that there's respiraphasic variation. I can say the inflow into the heart seems to be changing with each breath. I can say that the right ventricle may be collapsing a little bit because it's being pushed by something on the outside. But the only way to say the patient has tamponade is at the bedside. So keeping that in mind is important. And again, usually the story you'll hear is either preceding pericarditis. I've had like this nasty chest pain that gets a little better when I lean forward. Came after this illness started about a couple weeks ago. And more worrisome is if they have a traumatic cause. If they've got, I had an injury. I had a patient who had a motorcycle accident, and he came in with a tamponade because of traumatic injury to the heart. It's also commonly seen in patients with renal failure who've missed dialysis, because uremia can cause a significant pericardial effusion as well. So trauma, pericarditis, and renal failure are the three biggest things where we may often have an index of suspicion for tamponade. And if you find it, if you find pulsus paradoxus on exam, or if they've got JVD, muffled heart sounds, and a narrow pulse pressure, those are all great reasons to call cardiology as well. Don't wait for the echo to come back. That may often be one of the last things we can see is echo finding.
Is there anything else we missed?
Oh, yes. This is a common question that we're asked in managing heart failure. If a patient has an elevated creatinine, do you still diurese them? This is a question which routinely perplexes certain providers, but I just want to emphasize the reason that you may see elevated creatinine in patients with heart failure may be what we call cardiorenal syndrome. So cardiorenal syndrome is the renal complications of heart failure. But I do want to harken back to our talk on cardiogenic shock for a moment. There are two things that hurt the kidneys when you're in heart failure. One is you're not moving enough blood forward, which means you're not perfusing the kidneys. But the other factor is you're not decongesting the kidneys. If the central venous pressure is high because all that fluid is backed up in the right side of the heart, that means the blood isn't exiting the kidney as well, which means the blood can't flow into the kidney as well. So here too will be a situation where the patient may not be hypotensive, but their kidneys are acting like they are. And to make matters even more confusing, if you use some tricks like the FENA, it may look like a pre-renal physiology because it kind of is pre-renal. We usually think of pre-renal physiology in the setting of dehydration, but really the heart is before the kidneys in the circulation, so heart disease is also a pre-renal explanation for renal failure. When these patients come in with an elevated creatinine, the correct answer is to diurese them. And you will see a very peculiar phenomenon where the more diuretic you give and the more they diurese, the lower the creatinine becomes. Now, I didn't see as much severe AKI in pediatrics as in adults. Adult kidneys are by far more finicky than kids, but many people are accustomed to giving fluid for AKI. And while that's true in most situations, it is not true for heart failure. Likewise, you may see a patient with normal kidney function who you're diuresing for their heart failure, and suddenly their renal function begins to decline. This is a separate scenario. This isn't cardiorenal syndrome. This is truly that the kidneys are attempting to compensate for the diuresis that you're giving. It is not, however, the same thing as saying acute kidney injury. You may not necessarily be hurting the kidneys by continuing diuresis. So the kidneys are intelligent enough, I'll say, to recognize when the blood volume is lower than their normal set point would typically allow, because the kidneys don't see all the rest of the circulation. They only see what comes in through the renal artery. So in heart failure, they may be trying to preserve fluid. If you diurese them against their intention to do so, they may actually shunt blood away from themselves, constricting the afferent arteriole, for example. And then you may see the creatinine go up, not because the kidney is being injured, but because the blood is simply bypassing the kidney entirely. So when you see that, when a patient is still hypervolemic, it's not reason to back off. You're not necessarily killing the kidneys by doing so. It's just the kidneys may be fighting you a little bit, but it's still in the best interest of the body to decongest if they're fluid overloaded. So we don't back off on the diuretic if the patient is still obviously volume overloaded, even if the kidneys are worsening. It's also not uncommon that a patient goes into heart failure because they're going into renal failure. If the body isn't able to manage its volume in itself, you can go into heart failure, and then only after the fact do you find the kidneys aren't filtering as well as they should. So it may well be that the kidneys have a problem completely independent from the heart and independent of your treatment for it that will need to be addressed on its own. But we don't sacrifice the rest of the body to help the kidneys. Even if we are diuresing to the point that the kidneys are drying out a little bit, you're still more likely to have kidney complications by leaving the heart failure untreated. So often a scenario that we'll see is a patient who we're diuresing, the creatinine is going up, they're still markedly edematous, they still have JVD, their lungs are swimming in pulmonary edema, but their urine output drops off. And in that case, what we'll do is we'll diurese them harder, we'll put them on a bumetanide infusion, a Bumex strip, and if that doesn't work, we'll add a thiazide like Diaril. So doing that increases the potency of the loop diuretic significantly by, again, decreasing the kidney's ability to compensate. And when that happens, they often open like a faucet. And then you'll see the numbers start to improve. The creatinine will often go down again as they start to decongest. If that fails, the next step is usually dialysis. Now, obviously, along this path, if at any point things aren't going the way you think they are, it's important to take a step back and say, okay, am I considering the whole picture? Are they really wet right now? Is that edema really fluid overload, or could it be their amlodipine? Is the JVD really because they're overload, or could I be seeing a carotid impulse by mistake? Or maybe they have something like tricuspid regurgitation, where you might get some JVD with systolic waves as well. So if at any point things aren't going the way you expect, it's reasonable to give us a call or to step back and make sure that your treatment is having the intended consequence. Make sure they're actually putting out a liter per day. Make sure that they're actually getting the medicines that you've ordered and they haven't vomited them up, those sorts of things as well. But it can be a tricky diagnosis, and especially in the setting of an infection, there's a lot of differential to be considered.
Now, that was a great review on congestive heart failure and the potential complications. I have to say, I really appreciate. Before I keep going, is there anything more I missed?
Let me think. I think that will get you through 80% of heart failure patients, I would say.
I think for a pediatrician managing it, that's a nice review to kind of go over all the different parts of it. So at least they're familiar with it. And if whatever institution they're at, if they recognize as an issue and they may have forgotten exactly what to do, they know who to call.
Yeah, we're all being very collegiate during this time. We know that this is an unprecedented situation. Like we've sworn an oath not to take offense or roll our eyes at any consult we get, because the whole world is in a very unusual situation right now. And we're happy to help in any way we can.
Oh, that sounds good, because we're going to people are going to need it. There's just no way around it. A pediatrician seeing this for the first time. Hopefully the adult internist is managing a patient of this complexity, but it's very possible that the pediatrician could have to, depending upon where they're at.
Yeah, and again, heart failure is one of the 3 most common reasons for being admitted to the hospital. So it's very likely that you'll encounter this, even if you're explicitly trying to avoid the ones with adult chronic conditions, because it's out there. It's not uncommon. Everyone's going to have it.
Nate, this was wonderful. Thank you very much for joining us. I really appreciate it. You were great. It was a great lesson. I enjoyed refreshing stuff I had learned, but thanks a lot.
Oh, my pleasure. Thank you for having me.
And for those of you listening at home, remember CME credit is available if you just click on the link at the bottom of the podcast. This was the last of our crash course in adult inpatient medicine that I had planned on recording. If there are other things, if you're a pediatrician or a dermatologist or whatever, and you're taking care of patients because of COVID, adult patients, and there are other things you're coming up against, please contact the Popcorn Network or email me at tony.tarchichi, TARCHICHI @chp.edu. Let me know what you want to hear. We'll put it together. We'll do everything we can to help in as much as we possibly can. So please let us know. We're here to help as much as we can. I hope everybody stays safe, and I hope we can get back to pre-COVID podcast episodes on pediatric topics like brew and other things. Hopefully we'll get there soon, everybody.
Time for our acknowledgments.
We're doing all right.
I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast. It takes you to a web page. Create a free username and password. Answer some questions that I write that are not hard. And that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony, tony.tarchichi, TARCHICHI, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.